Thanks, Kelly. I appreciate the introduction. Thanks, everybody, for participating in this webinar. It's a pleasure to be with you today, this afternoon, or this morning, depending upon where you are. I'm going to talk about health savings accounts, where they're going, and what we've learned from some research that we've been doing here at EBRI over the last couple of years. If at any time you have questions, please go ahead and type them in, and I'll try to address them as I can. So, don't hesitate to ask any questions as they come up. What is a health savings account? It's interesting, a couple of months ago, I did a similar webinar, and at the last minute was asked to put in some background slides about what is an HSA, and my reaction to the sponsor of the webinar was, this is the 10th anniversary of HSAs. Do you really think I need to have that information in there? And not only was I asked to have the information in there, but we spent quite a bit of time just talking about what they are, more so than I expected to other webinars. So, I have a little bit of background here, and I apologize to those of you who know it. And it's probably good to have it in there for those of you who, even those of you who think you know it, because oftentimes the information is confusing, even after 10 years of HSAs being around. What is a health savings account? It's an account that was introduced or allowed by law as part of the 2003 Medicare Modernization Act. So starting January 1st, 2004, certain individuals could open health savings accounts. They're the best tax-free account out there when it comes to taxes. You get a triple tax advantage. Money that goes in on a tax-free basis. Any buildup of the account, and certainly in money market accounts, you're not going to get much interest these days, but you often do have the opportunity to have an investment portion of the account as well. Whatever accumulation there is builds up tax-free. And any money that comes out for healthcare services is distributed on a tax-free basis. In addition, there are certain premiums that could be paid out of an HSA on a tax-free basis as well. There are limits to how much money can go into an HSA. This year, the limit is $3,300 for people that have self-only coverage and $6,550 for people that have family coverage. There are catch-up contributions allowed if you're age 55 and older. You could put in an additional $1,000, which means if you have a married couple, both age 55 or older, the maximum family contribution would be $8,550. There is a quid pro quo in terms of making contributions. You can only make contributions to this account if you have a qualified high deductible health plan, also known as an HSA-eligible health plan. And those plans have minimum deductibles and maximum out-of-pocket limits that are statutory. They're set by law. So this year, the minimum deductible for a plan that, individual-only plan is $1,250, and the minimum family deductible is $2,500. And you can see what the maximum out-of-pockets are associated with these plans as well. So in order to put money in to an account, you have to have this high deductible health plan. But you could take money out at any time. That's important to know. So if you're working for an employer that offers an HSA-eligible plan and you build up an account balance over a number of years and you decide to leave your job, that money is yours. It goes with you, and you could use it at any time after you leave that job to pay your medical expenses. You do not have to be on a high deductible health plan or an HSA-eligible health plan in order to take money out. You can contribute to your account throughout, any time you have a high deductible health plan that's HSA eligible, and save that money until you want to take it out. There's no requirements that the money be distributed. In terms of how many people out there have HSAs or are on HSA eligible plans, there's lots of statistics out there. We conduct our own work. We think that there are 20.4 million People in the privately insured market, or about 14% of that market, in an HSA-eligible plan. Some of those people have opened an HSA, some of them haven't. And just note that just because you're on an HSA-eligible health plan doesn't mean you have to open an HSA. The HSA is actually optional. And we find about 16% growth between 2012 and 2013. And note that that 20.4 million is for 2013. We don't have 2014 estimates just yet. AHIP, which is America's Health Insurance Plans, estimates that there are 15.5 million people in the privately insured market, or about 10%, in an HSA-eligible plan last year. They found 15% growth. So our number's a little higher than theirs for different reasons. They conduct their surveys earlier in the year than we conduct ours. They only surveyed 91 health plans, whereas we rely on self-reports. So there's a number of reasons why the numbers are different, but we're basically in the ballpark. I think we're in the ballpark. There's a survey done by Mercer each year of workers. It finds that there are 18% of workers are in an HSA-eligible plan or an HRA plan. I didn't mention HRAs before. I'm just going to mention them in passing. Some would say that they're the precursor to HSAs. They've been around longer, and they look a whole lot like HSAs. They're a little different, but they tend to be in the same family of plans known as consumer-driven health plans. Mercer found 13% growth between 2012 and 2013. There are two other surveys out there that try and get at HSA and HRA growth combined. The NEHIS survey and the Kaiser Family Foundation, that's what KFF stands for. And both of those surveys find 11% enrollment, so in the ballpark of the other surveys, but they found absolutely no growth whatsoever between 2012 and 2013. So those are the major studies that try to put an estimate on how many workers or how many people out there have an HSA-eligible health plan. Devenir is an investment advisor which publishes an annual report on the number of accounts out there, and Devenir finds that as of December 31st of last year, there were 10.7 million accounts with $19.3 billion in assets in them. Note that the number of accounts should always be different than the number of people with an HSA-eligible health plan. At this point, 10 years out, I would expect the number of accounts to be less than the number of people with an HSA-eligible health plan, for the simple reason that every family that's enrolled on an HSA-eligible health plan will generally have one account. So if you are covering yourself and a spouse and 2 children, that's 4 people enrolled on the health plan, but chances are you only have one account across the 4 of you. At some point, that number, the 10.7 million, may be larger than the number of people enrolled in an HSA-eligible health plan, because at some point you're going to have people that no longer have the HSA-eligible health plan but have continued to keep the account. We've done some work in this area. It's going to be published next month. I'll give you a preview of it. I don't have a slide yet. It's still work in progress, but I'll give you a preview. What we're finding in the database that we've built, we have 1.5 million accounts in this database, and we're finding that about 1/3 of the accounts are accounts that don't have any contributions going into them in 2013. So neither the individual account owner put money in nor an employer put money in, and those are likely, we don't know for sure, but those are likely accounts that were opened prior to 2013 and no longer associated with an HSA-eligible health plan. So it's, if this is something you're interested in, I could certainly talk about it more later. But it's after 10 years, it's not as large of a market that it was originally projected to be, but it's growing, and you have to be careful about what number you're looking at, if you're looking at the number of people enrolled in these plans or the number of accounts out there, because it could get confusing very quickly. The offers of HSAs and HRA plans are expected to grow. This data comes from Mercer's National Survey of Employer-Sponsored Health Plans. And basically what it finds is that you could see the growth rates in offer rates between 2008 and 2013 for smaller firms, those with 10 to 499 employees. That's the blue line on the bottom. It shows that offer rates went from 9% to 23%, and you can see the similar higher offer rates, but similar growth patterns for larger employers. But you could see that the last set of data all the way to the right shows where offer rates are expected to be in 2 years. Pretty large growth. Employers are very interested in adding HSA plans where they're not already offering them. And many employers are interested in offering an HSA plan as the only plan option out there. In 2012, about 9% of employers offered only an HSA or an HRA, and by 2014, the expectation is that it's 23%. This survey was recently updated. I don't have it updated in the slide, and the estimates for 2015 are that about 30% of employers, and these are generally larger employers, 1,000 employees or more, it's expected that about 30% of those employers are only going to offer an HSA or HRA plan, also known as a full replacement plan, by 2015. And let me just note one thing. I haven't spent a lot of time, as I said before, talking about health reimbursement arrangements or HRAs. What we're finding in our survey work, and we've confirmed this basically in anecdotes, is that enrollment in HRAs fell for the first time in 2013 and is expected to continue falling. They never amounted to much, and so I think most of these projections for the prior slide, growth in offer rates as well as offering one of these plans as the only plan option, I think most of these projections are HSA growth only. And it shouldn't come as a surprise because the Affordable Care Act places enormous demands on employers. I'm not going to go over all the bullets here. You have them. You'll get a copy of the slides later this week. But these are all the things that employment-based coverage has to address that is expected to increase costs. So employers are no doubt looking to find ways to manage the expected cost increases, and moving to a high deductible health plan that's an HSA eligible plan is one of the things that employers are interested in doing to mitigate the expected cost increases. Already in the individual marketplace, HSAs have a strong presence. So there was some concern about that at first, but they account for about nearly 20% of the total offerings, and they're less expensive than non-HSA plans at this point. So let me turn to the work we've been doing at EBRI to evaluate HSA plans. We started a number of years ago, about 2 years ago, with data from a large employer in the Midwest that completely replaced its PPOs with an HSA-eligible health plan on January 1st, 2017. This employer offers its employees a choice of two different deductibles for individual coverage, $1,250, and a $2,500 option. They priced it as such so that 90% of the employees took the higher deductible option, the $2,500 deductible option, because there was no premium to choose that health plan. We got all their pharmacy and medical claims data, as well as insurance enrollment data over a 5-year period, starting in 2006. So we have data from an entire calendar year before they introduced the HSA, and then 4 years after the HSA was introduced. I haven't described it like this, but others have described it, our series of studies as the longest study of HSAs out there. It probably is. We haven't found anything else that looks at a continuously enrolled population over 5 years. You can see from that second bullet point from the bottom, 10,500 or 13,200 people continuously enrolled during the 5-year period. We've got a number of different studies that I'm going to go over, and some of them are able to follow 10,500 or 13,200 people over 5 years, which is a great sample to have to look at the impact of adopting an HSA. We actually have another study in progress. I'll give you a preview of the findings where we've been able to boost the sample size to over 18,000 people continuously enrolled over a 5-year period. So it's a very strong sample that we have. And we have data from a second employer that we use to create a comparison group. We've looked at things like use of healthcare services and spending associated with those services. So we've looked at inpatient hospital admissions, emergency department visits, outpatient office visits, prescription drug fills. We've also looked at cancer screenings not subject to any cost sharing whatsoever, even after the HSA was adopted. We've looked at medication adherence among individuals with chronic conditions. We've looked at the impact of moving to a HSA plan on generic drug rates. And we've also, as I mentioned, started looking at HEDIS quality measures. HEDIS is I'm not going to get the name of the acronym right, but it's a survey conducted by the National Committee on for Quality Assurance that looks at quality measures, and I'll give you a preview of some of the findings that we're working on, with the caveat that our work won't be published till later in the summer and it's subject to change. So just to give you a sense of the findings, we found that moving to the HSA-eligible plan reduced outpatient office visits. You can see here the blue line HSA group and increased for the comparison group, and then they both increased over the next 3 years. But you can see this gap where drug use or prescription drug use among the HSA group was lower in each year after the HSA was introduced. We did not find that the introduction of the full replacement HSA increased the generic drug dispensing rate. We did find that generic drug use fell and brand name drug use fell, but that brand names fell more than generics fell. And that's the reason why the generic rate went up, but there was, because both of those, use of both types of drugs, brand names and generics fell, there was no substitution of generics for brand name drugs. We've looked at medication adherence for people with chronic conditions. We found generally medication adherence falls over time, and we found that it fell more for the HSA group than the comparison group. And again, you've got the blue lines represent medication adherence for people with the HSA. The red line represents medication adherence for people in the comparison group. And you can see that for hypertension, for dyslipidemia, which is high cholesterol, I use dyslipidemia because it's, now that I can pronounce it without stumbling upon it, I like to say it. And diabetes, you could see that medication adherence fell for all three. People with all those conditions in the first year of the HSA. It looks like it's rebounding a little bit for the hypertension group and certainly for people with diabetes. You don't see a rebound for people with dyslipidemia. We also found that medication adherence fell for people with asthma, COPD, as well as for depression, although they're pretty close between the HSA and the comparison group for asthma and depression. Perhaps one of the most interesting findings is that in the third year of the HSA, which would be 2009, emergency room or emergency department visits increased in the HSA group. You could see that in 2006, 7, and 8, use of emergency departments was lower in the HSA group, and then they were the same in 2009, and then in 2010 they were higher. At this point, we have our theories as to why that's the case. We haven't been able to basically prove why ER visits jumped in the third year of the HSA. We think it may have to do with reductions in medication adherence in the prior years among people with chronic conditions, but we haven't been able to tease that out from our data at this point. So we can't say for sure that that's what's driving the higher ER use visits in the later years. We do find that, well, just so you know, this employer, before the ACA was passed, this employer that adopted the HSA was covering cancer screenings in full. So it was covering breast cancer, cervical cancer, and colorectal cancer screenings in full. It was not subject to the deductible. There were no co-payments whatsoever. Those services were covered at 100%. Yet in the first year of the HSA, use of those services all dropped for the HSA group. They eventually rebounded, as you can see in this chart for breast cancer screening, as well as this chart for cervical cancer screening, and this one for colorectal cancer screening. They all rebounded, but in the first year of the HSA, use of those cancer screenings had all fallen. So this brings us to the HEDIS quality measures. This is the work that we have in progress. The slides aren't as pretty. You'll see that in a minute. But we're looking at a number of different quality measures. We're looking at well, child, and adult annual physicals, preventive visits, as well as body mass index screening. We're looking at certain quality measures for adults, antibiotic prescription drug fills for people with acute bronchitis, imaging for low back pain. These are things that actually shouldn't happen according to NCQA. We're examining medication monitoring for people on certain medications like ACE inhibitors. We're examining LDL testing for people with cardiovascular disease. And we've also examined certain screenings for people with diabetes, adults with diabetes, HbA1c testing, eye exams, annual eye exams, LDL testing, and nephropathy screenings as well. For the most part, we don't find a whole lot of the expectation is that adopting a high deductible plan may have a negative impact on quality measures, but for the most part, we don't find much negative impact. We do find that, and here just focus on whether or not the numbers have a positive or negative sign in front of them and whether or not there are stars next to them. If there are stars, it means that the finding was statistically significant, and if there are negatives, it means that adopting the HSA had a negative impact on quality. We do find that in the first year of the HSA, and to some degree in the fourth year, there was a negative impact on preventive visits, annual physicals for adults and children. For the most part, we don't find any negative impact on these other variables other than medication monitoring is negative across the board in every year, which may be associated with fewer office visits in general. And for adults with diabetes, other than that negative in the upper right-hand corner for 2010, which is barely statistically significant for HbA1c testing, we find no negative impact whatsoever of the HSA on quality measures for adults with diabetes. Okay, so let me just wrap up by turning your attention to the impact on spending. This is quite a busy slide, and I apologize for that. What we've tried to do is show you what the percentage impact of adopting the HSA plan was on spending, overall spending, that's the top line, and spending by type of service. So you can see on the top, we find a 25% reduction in spending in the first year. It was quite a big reduction. It's larger than what most other studies found. But by the second year, we found only an 8% reduction. And keep in mind that each year is in relation to 2006. So in 2008, this total spending was still 8% below what it was in 2006. There was no difference between total spending in 2009 and 2006. But by 2010, total spending was still 6% below what it was in 2006. So not only did moving to the HSA plan affect trend, but trend was below overall spending 4 years after the adoption of the HSA plan. There was no impact on inpatient spending. You see it's negative 33% in the first year, but it's not statistically significant. There's no stars there. It's not highlighted red for your attention. But every other service we looked at in 2007 saw a reduction in spending relative to 2006. You start to see in 2008 those savings disappear. The emergency department savings disappeared in 2008. Outpatient office visits, outpatient services and office visits all saw their savings disappear in 2008. The only sustained savings we found was in laboratory services and pharmacy services. And you can see that those are red throughout the 4 years after the HSA was introduced. They're negative, they're red, and they're statistically significant. You can see that pharmacy is highly significant all 4 years after the HSA was introduced, with 3 stars next to it, whereas the laboratory savings starts to disappear. It hasn't quite gotten there in 2010, but there's only 1 star in 2010 as compared to 3 in 2007. In dollar amounts, savings per person in the first year was $527. By 2010, it was down to $132. And remember, this is savings relative to 2006. So total spending was $132 per person lower in 2010 than it was in 2006 for this employer. We broke out savings by spending quintile in 2006. So we're basically looking at, we've divided people into the lowest spenders in 2006. That's quintile 1 at the top, and the highest spenders in 2006. That's quintile 5 at the bottom of the slide. And basically, this is every service combined except for prescription drugs. And what we're finding here is that, for the most part, by the 4th year of the HSA, the only place we're finding savings relative to the year before the HSA was adopted is in that middle band. If you look, you find that negative 14% in the middle of the 2010 column. That's the only place where we're finding savings when we divide things by spending quintiles. So the lowest spenders, not surprisingly, aren't spending less because they were lower to begin with. But the highest spenders are also not spending less. It's those people in the middle, which I could argue are those people that have hit their deductible or have used the employer contribution to the HSA but haven't necessarily gone through their entire deductible. Whereas those people in the highest spending quintile at the bottom, they basically blow through their deductible every year. So the HSA plan has reduced their savings in the first year, but you don't find sustained savings for this population across the remaining 3 years of the HSA. When you look at the same picture for just pharmacy spending, you find an across-the-board savings. And this is no surprise. That's where we found the across-the-board savings and spending when we looked at just pharmacy spending for all quintiles combined. So you can see, regardless of whether you are a low spender or a high spender, other than the highest spending category, we find sustained savings in pharmacy benefits. And when you combine the prior 2 slides, when you put all healthcare services together, whether it's pharmacy or non-pharmacy spending, again, you're only finding sustained savings for that middle quintile, so people in the middle of the spending range prior to the HSA being introduced. My last slide is basically just a summary of all our results. I don't know that I'm going to go through this bullet by bullet. I think you'll get a copy of this, and I'm glad to answer any questions you have about it. Note that the last bullet here, we can't generalize our results because our research is based upon one employer, and if you see one employer, you've only seen one employer. So I don't want you to walk away thinking that if you did the same type of plan that this employer did, that you'd have a 25% savings in the first year you adopted the HSA-eligible health plan, and that you'd be spending less per person by year 4. You may or may not be. It all depends upon your population. But we've just looked at one employer, and over time we hope to look at a few more just to get a sense of how these savings vary from employer to employer. So I'll pause here. I'm glad to take any questions that you have. I think at this point, you would type them into the screen.
Yes, thank you so much, Paul. Ladies and gentlemen, just go ahead and type any questions you have into the questions pane at the bottom of your screen. One question, Paul. At this point, what do we not know about HSAs?
Oh, it's interesting. They've been around 10 years, but there's been very little research done on them, to be honest with you. Most of the early research conducted in this area has used data from health reimbursement arrangements. I think that maybe the most interesting research questions we haven't been able to get at yet on the HSAs. I mean, clearly, I would describe our work as trying to get to the longer-term impact of an HSA. We certainly haven't gotten to the long-term impact because we're only looking at 4 years after the HSA was adopted. But I think one of the most interesting questions is what's the role of the account? In our work, we're only looking at claims data. We're not looking at how the account, what impact the account has on use of services and spending. And I think some of the relevant questions are, one, are people not using the account and saving the money for retirement? And two, after a number of years, and I wish we could do this with our data, but we don't have the account information. After a number of years of building up an account balance, do people, what do people do? Do they buy up to a higher deductible health plan if they have that option? Or do they start using the account? Are they more likely to use the account for discretionary services that they wouldn't have used it for when they didn't have a large account balance? So, for example, does somebody with $50 in their account behave differently than someone with $2,500 in their account? We just don't know that at this point. Or do they not? Is there nothing different whatsoever? But we hope at some point that either we'll have this kind of data or other researchers will have this kind of data in order to start addressing some of these questions that haven't been answered yet.
Okay, thanks, Paul.
If you have any questions, please type them in. I'm glad to stick around till the end of the webinar to address any questions that you might have.
Another question that's come in general, do employers contribute to the HSA accounts, and what amounts?
Yeah, we're finding that about 70% of workers tell us that their employer contributes to the account. I don't know that I could generalize that to 70% of employers, but I think it's safe to say that more than half of employers contribute. We're finding in some of our other work in the data set, and we haven't released this yet, the data set where we are have 1.5 million accounts, that the average employer contribution, when there is an employer contribution, is just over $1,000. Where I can't remember some of the other findings from that to just rattle them off the top of my head, but $1,000 seems to be the average. It's probably lower for workers with employee-only coverage and higher for workers with family coverage, but I just don't know those numbers off the top.
Okay.
Kelly, have you got any other questions?
Well, I think we've had one more come in. One other question was, do you find that HSAs are increasing in popularity due to ACA? And if so, why?
Well, it's an interesting question because I don't know that we know at this point whether the growth in HSAs over the last couple of years have been due to the ACA or would have happened even in the absence of the ACA. So, back in 2004, just a couple of months after the Medicare law was passed that gave us HSAs, Mercer did a survey of employers and found that 73% were likely to be offering an HSA plan by 2006. Clearly that didn't happen. If you go back to the slide from Mercer that I showed you earlier, offer rates were much lower than 76% in 2006, and they're still much lower than that today. But while the initial growth projections didn't materialize, growth continued. And here we are 10 years later, and HSAs are anywhere between 15 and 20% of the market. But now I think the expectation is that, despite the fact that they would have likely continued to grow in the absence of the ACA, I think the fact that, those offer rates are expected to be so much higher 2 years from now, and the fact that you have so much more interest in moving to an HSA-eligible health plan as the only plan option for your workers, I think that that's more driven by the ACA than inertia.
Okay, and we do have another question that's come in. Paul, if you're okay with still chatting us up here. One of our attendees wrote in, what are some of the administrative or regulatory issues that employers should be aware of when offering an HSA plan to their employees?
Well, I think the big regulatory issue right now is how far can you push the envelope on what's considered preventive. Right now, cancer screenings can be excluded from the deductible. Anything that's considered primary preventive services defined by the ACA can be excluded from the deductible. But there's a lot of interest in excluding secondary preventive services from the deductible. Things like eye examinations for people with diabetes. Right now, that can't be excluded from the deductible, despite the fact that it's considered a high-valued healthcare service. So there's a lot of interest in doing something to allow secondary preventive services to be provided in full. But there's some questions as to how to go about doing that legally. Whether the IRS has to issue some guidance, whether they have to change the regulations, whether Congress has to rewrite the law. But I think it's just a matter of time before that's sorted out. So stay tuned for that.
Okay, well, I think that looks like everything. Paul, thank you so much for sharing so much information with us all today. And ladies and gentlemen, thank you for your participation in the webinar. If you don't mind sticking around and just taking 5 seconds to complete our survey, we would really appreciate it. Hope you all have a great afternoon. Thank you.